morning, and thank you for SAGES and the moderators for giving us a chance to present our work. These are our following disclosures. Dr. Ketan, none of them, however, are relevant to our presentation. Studies have demonstrated that laparoscopic bariatric surgery has dramatically reduced the wound infection rate from the open era. Historically, the rate of surgical site infections was between 1.8 and 10.5%, whereas today the rates are much lower, centered pretty much around 1%. And when wound infections occur during gastric bypass using the circular stapler, they usually occur at the site of the EEA insertion, which is depicted there. Surgical site infections continue to contribute significant morbidity, pain, and discomfort for the patient and remain one of the main reasons for readmission, accounting for somewhere between 4 and 14% of all bariatric readmissions. The economic impact of readmissions is estimated to be about $27 million annually on our healthcare system. And patients who develop a surgical site infection are 5 times more likely to present to the emergency room, 6 times more likely to be readmitted, and 5 times more likely to undergo an outpatient procedure. There are 2 techniques for anvil insertion when using the EEA stapler to create a circular stapled gastrojejunal anastomosis. The first involves utilizing the Orville device, pictured on the left, which is passed transorally down the esophagus and into the gastric pouch by the anesthesiologist. The second involves direct introduction of the anvil into the stomach via gastrotomy, pictured on the right. Our institution is an MBSA QIP Center of Excellence. We have 2 high-volume bariatric surgeons who for our study will be denoted as Surgeon A and Surgeon B. Surgeon A has traditionally utilized the transoral technique, whereas Surgeon B utilizes the transabdominal technique. In addition to the difference in the anvil insertion technique, Surgeon A has traditionally not utilized any wound protection at that EEA site, whereas Surgeon B has consistently used wound protection, which is an Alexis wound protector, and then draping of the EEA stapler with a sterile plastic. In performing our quarterly quality reviews to improve best practice and identify areas for improvement, we detected a higher than expected wound complication rate at 6%. Of particular concern was the development of 5 recent wound infections, which all occurred in the transoral group for a rate of 8.9% in that cohort, and when cultured, grew oral flora. Thus, we were left questioning the safety profile of the transoral technique, and we wanted to know why, and whether or not the main contributor to the development of a wound infection was the technique for the anvil introduction, or was it the difference between surgeons' utilization of wound protection or not. Our hypothesis then was that we could improve our institutional wound infection rate by either adding wound protection to the transoral technique to protect the wound from oral flora, or shifting towards the more frequent use of the transabdominal technique. On May 16, 2017, Surgeon A made 2 changes. For a subset of patients, Surgeon A adopted the transabdominal technique. However, due to comfort level and expertise and experience, Surgeon A added wound protection to the remainder of the patients utilizing the transoral technique, and Surgeon B made no changes to their technique. Our study involves consecutive patients that underwent a bypass from January of 2016 to June 30th of 2018. This is just a timeline of our intervention. We define Group 1 as before and Group 2 as after. 3 surgical site infections had occurred in 2016 and 2 in early 2017 prior to our quality review. And then after our intervention, there were no surgical site infections. This is just a pictorial demonstration of our wound protection. The picture on the left shows the EEA stapler covered with a sterile plastic drape. The middle picture is the Alexis wound protector at the EEA insertion site. And the picture on the right shows passage of the covered stapler through the wound protector. And then after creation of the gastrojejunostomy, the stapler is retracted into the plastic and then removed through the wound protector. We noticed no demographic differences between the 2 groups, as most patients were female, around the age of 44, and a BMI of around 45 or 46, and the prevalence of diabetes, which is a known risk factor for wound infections, was also similar between groups. When looking at the frequency of the EEA insertion techniques, we noted an increase in the transabdominal technique, as Surgeon A now performed 17 transabdominal after the intervention, so from 69.2 to 75%, and Surgeon A continued to use the transoral technique in 37 patients after May. We noticed a significant reduction in total wound complications from 6% to 1.3%, and we noticed complete elimination of the surgical site infections after adding wound protection to the transoral technique. When stratified by technique, the transabdominal had 3 hematomas and 3 seromas, and we saw elimination of the surgical site infections, which was a result from 8.9% down to 0. We defined revisional surgery for our study as conversion of a sleeve or a band to a bypass. We noticed no difference in the prevalence of revisional surgery before or after in groups A or B, and noted that revisional surgery was not associated with an increased risk of surgical site infection, as none of the surgical site infections occurred in our revisional patients. Other authors have reported similar significant reduction when they added preventative measures intraoperatively. They've removed the GJ enteric remnant through a sterile specimen bag, placed a Penrose to drain the port site, or irrigated the wound, loosely approximated the skin, or packed it. One study did a preoperative chlorhexidine swish and swallow, and then one study even went so far as to planned secondary wound closure on post-op day 3. The limitations of our study include the following. There are many other contributing factors to the development of a wound infection, which are intraoperative and patient-specific, and we couldn't control for those, or did not in our study. Our incidence of a surgical site infection was relatively low. The choice of the anvil insertion was determined by the operating surgeon and wasn't randomly assigned, which adds some selection bias, and it was a retrospective review of our data. So in conclusion, we found that our quality improvement intervention was efficacious and decided that it was not the technique of anvil insertion, but it was the use of wound protection that was key to preventing the wound infections. And we saw complete elimination after we added wound protection to the transoral technique. And thus, our conclusion is that using proper precautions, the circular stapled anastomosis can be done using either technique for anvil insertion, and that overall self-assessment of outcomes leads to best practice. And then I'll take any questions.